Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, everyone, and welcome back to the CEI HIV Primary Care and Prevention podcast. I'm Tony Urbina, Medical Director of CEI's HIV Primary Care and Prevention Center of Excellence and Professor of Medicine at the Icahn School of Medicine at Mount Sinai, and your guide through the latest in HIV medicine. I want to start with the patient, really a composite of people I'm sure you all have in your panels. Virologically suppressed for years, doing everything right, whose cardiovascular risk on paper looks completely reassuring. And yet by every signal that actually matters, he's someone I want on a statin. That gap between what our risk calculators tell us and what our patients actually need is exactly what's been shifting in the guidelines this year. Today, we're covering cardiovascular risk assessment in people with HIV, how to use the new American Heart Association prevent equations, and the 2026 cholesterol guideline alongside our HIV-specific guidance to decide who gets a statin and which one. And by the end of this episode, you'll walk away with three things: why our standard risk calculators underestimate cardiovascular risk in your patients with HIV, what actually changed in the 2026 Dyslipidemia Guideline from the American College of Cardiology and the American Heart Association, the ACC and the AHA, the two bodies I'll be referring to throughout, including a quiet but major shift that turns HIV itself into a treatment indication, and a practical Monday morning approach to statin selection that accounts for interactions with antiretroviral therapy, or ART. Let's get into it. Let's start with the core problem because it frames everything else. People with HIV carry a substantially elevated risk of atherosclerotic cardiovascular disease, ASCVD. Even with fully suppressed virus, even on modern antiretroviral therapy, the risk of heart attack and stroke runs higher than in people without HIV of the same age. The drivers are familiar: chronic immune activation and inflammation that persists despite suppression, the effects of the virus itself, and traditional risk factors that cluster in this population. The point is, this isn't simply traditional risk plus HIV. There's something about treated HIV that independently pushes cardiovascular risk upward. Now, here's the clinical trap. The tools we use to estimate that risk were not built for our patients. For years, the US standard has been the pooled cohort equations, the PCE, developed and validated in the general population, and study after study shows the same thing. The PCE underestimates cardiovascular risk in people with HIV, and it doesn't underestimate evenly. The underprediction is worse in exactly the patients we most need to get right: women with HIV, Black patients, and people whose calculated risk lands in that low to moderate range, which is where most of our patients sit. So picture that patient again, the one from the top, middle-aged, undetectable for years, well-controlled. You run his numbers and the calculator hands you a reassuringly low 10-year risk. Stop there and you've potentially missed someone quietly accumulating atherosclerotic disease right in front of you. A number that was true for the general population and wrong for him. The cardiology and HIV communities have understood this for a while, and the workaround has been the concept of risk enhancers, factors the calculator doesn't capture that tell you to treat the estimated risk as a floor, not a ceiling. The 2018 cholesterol guideline gave us general population risk enhancers like family history of premature heart disease, persistently elevated LDL, and chronic kidney disease. And the AHA's scientific statement on HIV layered a set of HIV-specific risk enhancers on top of that. So the workflow became run the calculator, then look at your patient and ask what the calculator missed. For people with HIV, the answer was almost always a lot. And that's the background against which everything changed this year. Which brings us to the new risk tools. In 2023, the AHA introduced a replacement for the pooled cohort equations called PREVENT, predicting risk of cardiovascular disease events. On paper, it's a real improvement, built on more contemporary, more diverse data. It folds in kidney function and body mass index, drops race as a biological input in favor of a social deprivation measure, and extends risk estimation down to age 30, giving both 10-year and 30-year risk. The 2026 ACC-AHA Dyslipidemia Guideline, released this past March, formally adopts PREVENT as the preferred calculator over the old pooled cohort equation for adults 30 to 79. Going forward, PREVENT is the tool. But, and this matters enormously for our patients, PREVENT predicts substantially lower risk than the old equations. The guideline writers note the pooled cohort equations overestimated 10-year risk in the general population by something like 40 to 50%. The new categories reflect that. Under PREVENT, low risk is under 3%, borderline 3 to 5, intermediate 5 to 10, and high 10% or above. One feature of PREVENT that suits our patients is the 30-year estimate. Many people with HIV are engaged in care in their 30s and 40s, where a 10-year window can look deceptively safe, while the lifetime trajectory is anything but. So the 30-year number lets you start the prevention conversation earlier. The guideline also lowered the bar generally, with treatment on the table at a 10-year risk as low as 3% once risk enhancers are factored in. Now sit with the implication. We started with the calculator, the pooled cohort equation that already underestimated risk in people with HIV. And now the field is moving to one that produces even lower numbers for everyone. If you relied purely on a risk threshold to decide who gets a statin, switching to PREVENT will push a lot of people with HIV below the line. And there's research applying PREVENT to a real-world cohort of people with HIV. It predicts much lower risk than the pooled cohort equations, meaning far fewer would qualify for statins under a pure threshold approach. The authors were direct. Without recalibration, PREVENT shouldn't simply be applied to people with HIV as is. So you can see the paradox. The same patient, the one who already looked reassuringly low risk, would look even lower risk under PREVENT than under the pooled cohort equation. The better, more modern calculator applied naively would make it easier to talk yourself out of treating him. That's the tension the 2026 guideline had to resolve, and the way it resolved it is at the heart of this episode. Here's what the 2026 guideline did, and it's generally important for how to practice. Rather than leaving people with HIV at the mercy of a calculator that underestimates their risk, the guideline moved HIV into a different category entirely. In adults aged 40 to 75, HIV infection is now listed alongside diabetes and chronic kidney disease as a condition for which lipid-lowering therapy is recommended for the primary prevention of cardiovascular disease, regardless of the calculated risk score and regardless of the LDL level. This is a class 1 recommendation, the strongest tier. Let me say that plainly because it's a shift in the mental model. For your patient with HIV between 40 and 75, you no longer start by asking the calculator whether they clear a threshold. HIV itself is the indication. The default becomes this person should be on a statin. The calculator is now for refining intensity and the conversation, not the yes or no decision. And this didn't come out of nowhere. It rests on PLHIV, the randomized trial to prevent vascular events in HIV, one of the most important cardiovascular trials in this population. PLHIV enrolled nearly 8,000 people with HIV, ages 40 to 75, on ART at low to moderate cardiovascular risk. By design, people who under the old rules wouldn't have qualified for a statin. Median 10-year risk at entry was about 4.5%. They were randomized to pitavastatin or placebo, and pitavastatin cut major cardiovascular events by about 36%. The trial was stopped early for efficacy, a population our calculators called low risk, and a statin still prevented roughly a third of cardiovascular events. That result drove our HIV-specific guidance even before the cardiology guideline caught up. After reprieve, the U.S. Department of Health and Human Services panel with the AHA, the ACC, and the HIV Medicine Association, or HIVMA, recommended at least moderate intensity statin therapy for people with HIV age 40 to 75 with an estimated 10-year risk from 5 up to 20%, with a specific nod to pitavastatin. For those below 5%, the guidance was to have the conversation weighing a more modest benefit against the patient's preferences. So let's put the two together. Our HIV guidelines post-reprieve already lean strongly toward treating, and now the 2026 cardiology guideline has gone a step further and made HIV a categorical indication in the 40 to 75 window. The two frameworks have converged on the same practical message. For most of your patients with HIV in middle age, the question isn't really whether to consider a statin, it's why you wouldn't. And the European guidance has gone even further. The 2025 European update recommends a statin for essentially all people with HIV age 40 and over, regardless of calculated risk. You don't have to adopt that wholesale to take the signal. Across multiple expert panels, the arrow points the same way. One caveat worth stating: above 75, this becomes individualized, a shared decision conversation rather than a default. And reprieve doesn't tell us about people under 40, but for that broad 40 to 75 group, the direction is clear. All right, let's make this practical. You've got a patient with HIV 40 to 75, and you decided a statin's on the table. Two questions follow: which statin, and what about interactions with their ART? This is where HIV primary care earned its keep. Statin selection in our patient isn't the same as in the general population. And the governing issue is metabolism. Several statins, simvastatin, lovastatin, and to a lesser degree atorvastatin, are metabolized through cytochrome 3A4. And some antiretrovirals, particularly the pharmacologic boosters ritonavir and cobicistat, are potent CYP3A4 inhibitors. You put those together and you can drive statin levels sky high, raising the risk of myopathy and rarely rhabdomyolysis. So the hard rule first: simvastatin and lovastatin are contraindicated with any boosted regimen. Any protease inhibitor or cobicistat, don't use them. That's an FDA level warning, not a soft preference. Now the good news: the statins we actually reach for in prevention can all be used here. You just have to respect the regimen. Pitavastatin, the reprieve statin, has minimal interaction with antiretrovirals and is a clean first choice. Rosuvastatin is a strong option too. It isn't a CYP3A4 substrate, but it still interacts through the drug transporters OPB1 and BRCP, which the boosters inhibit. So with a ritonavir or cobicistat boosted regimen, you start low and cap the dose. No higher than 10 milligrams with ritonavir boosted atazanavir or lopinavir, and up to 20 with a darunavir-based regimen. And atorvastatin, with a lot of us reach for first because it's cheap and generic, absolutely has a place. It's a CYP3A4 substrate, so with a boosted regimen, you start low, titrate carefully, and generally cap around 20 milligrams a day, staying near 10 with cobicistat-containing therapy. Pravastatin is also reasonable, though less potent. And here's the context that makes all this easier than it used to be. Most of our patients today are on integrase strand transfer inhibitor-based regimens or INSTIs like dolutegravir and bictegravir. These are essentially lipid neutral and don't carry these dangerous statin interactions. So the patient most likely to land you in trouble is the one on an older or boosted regimen, a boosted protease inhibitor or cobicistat-containing therapy. Those are the charts where you slow down and check before you prescribe. So my practical algorithm: confirm the patient is 40 to 75, HIV is your indication, no need for the calculator to clear a bar, look at the ART regimen. On an integrase inhibitor with no booster, which is most of our patients, you have wide latitude: atorvastatin, rosuvastatin, or pitavastatin at a standard moderate intensity dose. On a boosted regimen, start low and cap: pitavastatin, low dose rosuvastatin, or cap dose atorvastatin, and steer clear of simvastatin and lovastatin. Then have the conversation. A few quick add-ons. Moderate intensity statin is a reasonable default here. Titrate it to response. The 2026 guideline also nudges us to check a lipoprotein A once in every adult, a cheap one-time test that flags an inherited elevation the standard panel misses. And none of this replaces the basics: blood pressure, glucose, smoking cessation, diet, and activity still do work. If LDL stays stubborn on a tolerated statin, ezetimibe is an easy interaction-friendly add-on. The statin is the anchor, not the whole strategy. And on that conversation, this is where you preempt the muscle symptom worry your patients have heard about. Be honest, Reprieve did show slightly more muscle-related symptoms and a small increase in new diabetes in the statin group, but discontinuations were uncommon, and the cardiovascular benefit clearly outweighed those risks in exactly this population. Frame it the way it deserves to be framed. This isn't piling on another pill. It's one of the highest value preventive things we can offer a person aging with HIV. We've spent a generation getting people to undetectable and helping them live long lives. Protecting their heart is the next chapter of that same work. So to bring it home, 3 things to carry into clinic. 1, standard calculators underestimate cardiovascular risk in people with HIV and prevent, though a better tool pushes estimates even lower. So don't let a low number talk you out of treatment. 2, the 2026 ACC AHA guideline now makes HIV itself a class 1 indication for lipid-lowering therapy in adults 40 to 75 years of age. And 3, when you start a statin, pick one compatible with the regimen. Pitavastatin or rosuvastatin or atorvastatin are your friends, and simvastatin and lovastatin are off the table with boosted therapy. I'm Tony Urbina. Thank you for listening. We'll be back soon with more updates from the field. In the meantime, stay engaged, stay current, and take care of yourselves and your patients.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.